for example, there are mice studies that have shown that mice that have been purposely caused to develop menopause through basically chemotherapies have had improved fertility after using PRP treatment. There are multiple studies out there, none randomized controlled trials, but there have been multiple studies out there that have looked at women given intra-ovarian PRP. And what it's shown is a lot of times their AMH levels will go up, their FSH levels will go down, and even antral follicle counts can actually go up. And so we can make that next conclusion that if those things are improving, then potentially we should be able to get more eggs and potentially be able to get a better chance at pregnancy. And so when you look for the arguments for it, I think you can also make the argument that what is there to lose? Very few people are taking this who don't need it. So if someone comes in who's 25, who's already making 18 eggs, they're not really asking for PRP therapy at this point for ovarian rejuvenation. But people who are at that point at the end of the road and they're like, I have no other options, I've tried everything else. I guess the question is, what's the harm? And so one of the pros for taking is that there appears to be plausibility.
Sometimes it's just a low efficiency environment, and that's okay. But you eventually get there. And I think that's the key.
Gotcha. Well, thanks so much. Is it okay if I ask one more question?
Of course.
Yeah.
So we had suspicions that I had a varicocele, and then also, well, we know from different blood work over time that, I just have low testosterone levels. Went to a urologist, and then did ultrasounds. Both ultrasounds showed that I didn't have a varicocele. And so my question is, as we try to ramp up for another retrieval and fertilization, are there specific things that I can do to try to increase not only my numbers, but just the overall health of my sperm?
I'm excited to see what the future holds with AI.
Yeah, I think it's one of those things, like the parallel that I think of is like radiology, where, the embryologist by themselves is really good. And the AI by themselves is not as good as the radiologist. But when you pair the AI with the embryologist or with the radiologist, it's even better than the embryologist or the radiologist alone. So do you think that's kind of where we're going?
I do think we're going to get there for sure. I think we're really close. Like I said, 3 to 5 years, I think we're going to have something out there that really changes the game in terms of, selecting embryos for transfer. Just the time-lapse imaging alone has given us so much information from an embryology perspective. Like, we're able to see things that we were never able to see before. So like things like reverse cleavage, where you're seeing an embryo on day 3 that's got multiple, maybe it's a 3-cell, it's not the best looking day 3. And then it reverts back to a 2-cell, like things like that we couldn't catch before because, that time lapse is taking a picture every 10 minutes, but we're not taking the embryo out of the incubator every 10 minutes. So we're just getting so much more information, and we're going to get better at using all of that data to tell us something about the embryos or the outcome. So I'm excited about it.
Very cool. Very, very cool.
Well, we have a guest here, Melissa, that we're bringing on the stage here that you can talk to. And Melissa, how are you doing?
Yeah, good. How are you?
Fantastic. Well, we have Elise here who's answering questions. So, I mean, if you want to know the secrets of the lab, she's all ears.
And so, for example, in Massachusetts, that's kind of the classic example that comes to mind, where, IVF is mandated. There are some guardrails around it, but by and large, everybody has access to IVF if they, fulfill a diagnosis of infertility. And I think what's really interesting there is, if we explore that on a whole national level, the first thing that comes to mind, of course, is cost. I mean, this is a pretty costly thing to just roll out to everybody. And I've seen some estimates out there from some think tanks that would put the number at around $7 billion. So that's the first big thing that kind of jumps out at me. That's roughly the cost of our federal program for public housing. That's a big line item. The other thing that's interesting here is, hey, does this change behavior, right? Like if people know they've got IVF, is there a world in which people start to wait a little bit longer to have their children? They're like, well, if I struggle, I could always do IVF. Is there, kind of a over reliance on fertility treatment? And you and I both know very well, the older you get, the less effective IVF gets. So does that balloon the costs up even more? And then I think there's another point, and you touched on this, and I'd love to hear more about this, is this idea of like, compelling taxpayers or maybe religious entities and employers to subsidize a program that maybe they don't agree with. And I think that's where, the rubber starts hitting the road on kind of making it sort of either mandated, which is one model, saying the insurance companies have to pay for it. And then the other one, which he very interestingly said, hey, the federal government is actually going to subsidize this, which would, by all measures be very, very costly. And I think one thing that we wanted to share today are kind of differing perspectives, maybe similar perspectives about, what our patients can do as they go through the process of IVF to manage their mental health wellness. And I'm not saying that it's going to be a breeze or there's kind of some silver bullet here, but there are some different strategies that we've come across over the years, just with our experience, seeing a lot of things that work, things that don't work. And I think there are different approaches that work for different people. There's not a one size fits all for managing mental wellness and anxiety as you go through IVF. And so maybe a kind of a fun way to do it today, I don't know what you think, Dr. Amos, like we could just talk about some of our favorite things that we've seen that people have done for managing mental health and anxiety as they go through IVF, and what we think has worked best. Just some of our opinions around some of those things.
Yeah, I mean, like you said, it was a big portion of the conference, and we were just talking before we got on. I was saying how stress is one of those weird things because it's something that we know can affect the patient more than it even affects the cycle. But the thing is that if you're stressed out so much that you can't continue moving with the cycle, or that, you're not even able to enjoy the cycle, it becomes very stressful as well.
And we might get there. And it's really exciting that maybe we find a group of patients that really benefits from PRP. But we still haven't, in my opinion, found that group perfectly. And once we do, I do think that there's going to likely be benefit, but we're just not there yet. So I don't know if it's prime time 100% for everyone. There are those, let's call them edge cases where, just like you were talking about, Dr. It was like, people have tried a lot of things and this is kind of their last shot at it. And they want to say, well, I don't want to leave anything on the table. Maybe there's some early data around this. I'm willing to basically try it. I'm willing to kind of experiment here. And I think that's okay in certain cases, as long as our patients really know that that's where that lives. But I also, want to just throw out that the treatment is often not free. So outside of a clinical trial, you have to, pay for all the procedures in the lab and the procedure to do the mock retrieval kind of thing where you inject the PRP. And so there's this cost component as well. And in some places, I've noticed that this can be really expensive. It's kind of like, wow, I've seen some really high prices, but I don't know. That's my spiel about the cons. I'm really excited to see what comes in the future with it. And I think there's going to be a group of patients we can really help with it.
Yeah. Yeah, I mean, before we started talking about this, and again, you and I share very similar views on this with regards to it's very exciting. Anytime we can do anything to help, our patients, it's always exciting. But the question is, how much are we helping? My question is, and I think this is a very fair question to ask, I'm not trying to put all the other clinics on the spot here, is how is it we're able to do it for so much less, still have the same rates, and other clinics charge 3 times the amount? And I think that's the real question. And I think that's something they're going to be looking into is it really that expensive? Or is it just that we in this country, people are being taken advantage of? Because we all know, I mean, again, I'm not trying to call out the pharmacies and all, but you can go and buy Menopur here in the States and you're paying $90. But if you go to, Europe
Mhm.
And many people know about many websites where you can get meds, you get it for a third the cost.
Right.
And I've even brought this up to the companies. I'm like, hey, why is it so much more expensive here? And they're like, well, the quality and stuff. And I said, well, so you're giving crappy meds to other countries? And they're like, well, no, it's the same meds. I'm like, so why is it 3 times more expensive? And that's just for the name brands. You go to generics like some of these other countries do. That's the thing I think they're going to find out in this EO when they make this thing. It's like, wow, is it just a lot of doctors wanting, to be rich, or is it really that it's this expensive? And I mean, it's not cheap, no question about it. No one's going to ever get IVF for $200. But it's not as expensive as people think. And
Right.
that's the thing I think
it doesn't have to be as expensive as it is in many places.
Yeah.
And I mean, what you're talking about has the kind of an extra layer of complexity too, because is it that it doesn't need to be as expensive as it currently is across the board with the national, cost of fertility services, in my opinion, and yours being far too high? Or is it that maybe there has been over time a built-in inefficiency to the whole process? And, obviously we're not going to answer that question tonight, but it is an interesting question. And I think that's going to definitely be something that, many experts, policy experts, et cetera, really start kind of scrutinizing this type of thing as they're going through it. What
just wonder what would you tell someone to look for when they look for a clinic?
Yeah, I think that you can still use the CDC data a little bit to just get a sense of, hey, how good is this clinic's lab? Because that tells you a lot, because IVF is a lot harder than egg freezing, right? So from a technical standpoint, the IVF process is much more sensitive than the egg freezing process. So usually places that are good at IVF are very good at egg freezing, and vice versa. But meaning if they're bad at IVF, they're probably not going to be very good at egg freezing. I think the other part of it is making sure that the clinic and the doctor are a good fit. You have very different needs as a patient who's going through the egg freezing process. And you just want to make sure it's a good fit. And so sometimes it's fair to set up an appointment, talk with your doctor, and check out another clinic. And I encourage everybody out there to do that, because I think sometimes you'll get a much better feel for where you belong, what's a better fit. But that's my 2 cents. I don't know. What about you?
Yeah, I think that's a fair point. I think clinics that have, when I say good pregnancy rates, like in the upper echelon, they're one of the top clinics, I think you can make a pretty fair guess that they're going to be decent at the egg freezing as well. Because you're right, it's just one portion of it. But and some of the difference between clinics have really shrunk now that we have protocols that pretty much everyone's using, very similar protocols. Whereas in the past, there were some protocol differences. I mean, there's no question freezing a egg 6 hours after taking out versus 2 to 3 hours can make a difference in the success rate of that egg. So there are definitely changes. I've told people, and again, I don't know if I'm wrong by telling them this, but I feel like if a place has their own egg bank, right, I think they got to be pretty good at it, right? Because it's pretty hard to sell eggs to other people if you can't even thaw them that well, right? So if everyone's losing half their eggs, you go, well, they're not good at this. So I feel like that's something I've always felt is something to look at. And then I think even donors, I think that's another one where, they're thawing eggs. But I've always thought of that. I feel like how do you define it? But I think that's a fair thing you said. I think there's enough consolidation now in the way we thaw eggs that I think you're right. You could probably use that. Whereas back in the past, I mean, you couldn't. Everyone was thawing slightly different how they were freezing eggs, and I think there's a little bit more consolidation in that area. My joke I always tell people is like, everything always looks good on day 3 because it's just so early. And I tell them it's like when people go for a job on orientation day, everyone looks amazing because no one's done anything, right? Even 3 days later, you're like, John and Sally are great, but it's on, 2 weeks later, you're like, John sucks at his job. Like, we got to get rid of him. And that's day 5. It's really allowed a lot of dignity to get there. And so this idea of what's better, the question that they're asking is it possible that some embryos are not making day 5 because the environment is bad. And I think that's absolutely true back in the past. But as you mentioned, the culture environments are getting better and better. We're not making our own media. We can't have the wrong amount of percentage now.
Independent providers out there, either mental health providers or in many cases, acupuncture. And so, acupuncturists offer a great service, and many of my patients have gone to see an acupuncturist. And what I tend to hear from them is more about the wellness experience that they have, meaning they come back and they say, every time I do acupuncture, I just feel much better afterwards. I feel decompressed. And, I always say it's very difficult to study Eastern medicine through a Western lens. So Western lens being kind of the type of medicine that we do, Eastern or, acupuncture medicine functions in a little bit of a different realm, a different space. And so I really appreciate that, we can kind of marry the two. And I think that a lot of our patients who are, open to something like acupuncture get a ton of benefit from it. Now, obviously, if you're like deathly afraid of needles, probably not the place you want to start, but have had, tremendous like experiences with people coming back and just saying, this really worked for me. I feel a lot better. Having another person also on your team, I really think there is benefit to that, to having another person that you can bounce some ideas off of, talk to them about your experience going through IVF, and they're outside of the four walls of your fertility clinic. I encourage that. I think it's wonderful. But that's another one that's high on my list of things that people have done that's really wonderful.
There's some cultures too that things are even more stressful for, right? So, I mean, it's actually not even allowed in Catholicism to do IVF. A lot of times when I see patients who are Catholic, they don't want anyone to know. And so how do you take something like IVF that an entire religion doesn't allow and then say, but now you have to offer it? So that is one of the biggest pushbacks that I see. Personal pushback, I agree with you. I don't think that's ever like a personal religious thing is not a big thing. I see the same. I think it's God works through us to do this. So I'm like, if God didn't want us to do this, he wouldn't have allowed us to do this. So I agree with you on that. But
and I guess all Catholics are different. I know some Catholics and they've changed their mind on it because they go, we need babies, and people that want to have babies are great. And hey, let's have babies and let's support the doctors that want to help us make babies.
But that's more on the individual standpoint. Like I said, on the larger standpoint, when you talk about lobbyists and things like that, it is still a big pushback. The second thing I would bring up too is the economic. We really hope a lot of people are interested in, coming in. It doesn't matter what state you're from. Obviously, anyone could be affected. And so we're going to kind of talk about, how things can affect it, what type of things you need to be worried about or not worried about. And so, Dr. Sam, one of the things I thought was really interesting was, not just how does the president affect it, but kind of like, even if they wanted to do things, so that'd be great for us to talk about, like, what if someone wanted to do something? Like, what if Trump or someone wanted to make a national abortion? Like, is it even possible and stuff like that? And so I think, it would be great to kind of talk about stuff like that. Egg freezing. I've had a couple of patients recently was worried about with egg freezing, if that's going to affect them. And then I thought another thing was interesting is California, usually being the first one to do things, went and passed a law mandating fertility, IVF. And so I thought, it'd be kind of neat too to talk about that, because obviously both candidates talked about, making IVF mandated. And so it'd be kind of interesting. And so, like I said, love to kind of hear your 2 cents on this. And then what we'll do is we'll get, we got someone in the background already that we'll bring on to see what questions they have. But, what do you think?
And can you just talk to us like really quickly about like what that developmental stage just looks like to be able to do some of these very complex things?
Yeah, so it took me almost 5 years to be fully trained. So it's a long
5
time.
years. I'm just looking at
Yeah.
this. Wow.
Yeah. So I started in andrology, which is semen analysis, IUI prep, a little endocrine if you're running like a blood analyzer machine. And so training takes such a long time because of a couple reasons. Some of it is you still have to do your daily work and then try to squeeze in training on the side. So I'd have to convince a senior embryologist to stay 30 minutes after or leave your needles up for me to practice things here and there. And I think there is a big misconception that training embryologists are just out there wild, wild west sort of thing. And that's very much not the case. So we are junior embryologists and training embryologists are monitored in every single thing that they're doing. And it usually starts with some sort of discarded or donated specifically for training material, whether that's eggs, sperm, embryos from a patient. We're working on those things before we're allowed to work on patient cases. So most labs have a training expectation, a training guide. You have to observe this many times. You have to work on discard eggs, embryos, or donated eggs, embryos this many times. Then you get to do 1 egg out of a case of 20 eggs. Then you get to work up to 3 eggs and 5 eggs. And then you're splitting cases 50-50. And then you're the lead on a case. So you're doing majority and the senior is doing a little bit, all while being monitored. All of your statistics are being evaluated at every step of the way. And then you have to do a certain number by yourself under observation. All the stats have to work out. And then you're able to do things on your own.
Yeah, let's start with this question right here. I think it's a great question. And it says, hey doctors, Fargo here. Question for you: is there any benefit to a fresh transfer if not doing PGS testing? And so her specific example is, is there less chance of damage when you don't freeze it in the thawing? And again, if you want to answer this one, I can definitely give the generic answer, which is the difference between statistical differences and differences, right? And so, statistically speaking, no, there's really not that big of a difference. So, because the risk of the embryo is so low with freezing it and thawing it that the statistical chance is not better. But obviously, it's like someone saying, your statistical chances of getting shot in Chicago is low, but if you're the guy getting shot, it's 100% at that moment. And so there is an absolute technical risk of, yes, anytime you freeze it, you do add that risk, but it's so small that it really shouldn't make someone want to do a fresh transfer. Right. I don't know what you would have to add to that.
Yeah, no, I mean, I think I that's the way I kind of phrase it. I mean, I think that, every time that you do anything to an embryo, I mean, it's like, is there extra risk in driving an extra mile on the freeway? Just to use another example. And yeah, there is a little bit of risk there.
And wouldn't you know that my very next transfer, I had a successful baby. So, I mean, it must have been the fertility statues, right? Like my husband's right. So, but my husband's like, you are a scientist, you are a physician. Like, why do you believe in this stuff? And I was like, because like science doesn't explain everything, right?
Yeah, that's why I thought of that, because I was telling her, because she said, is it goofy that I think this? I said, no, it's not. When you have infertility, you think things. So this next person's coming on. She actually was on with us last week when we were talking about this, and again, we've never been in mandated state, and she had some really good questions. Some of the questions she was asking were things like, are they going to make me jump through hoops, like when there's mandated? Are they going to have more restrictions and things like that? And that's the stuff we were talking about, but we don't know firsthand. So I'm really looking forward to talking to Joanna, because she has some great questions. She's in California, so she's going to be one of those people who are going to be able to benefit from it. And I know, Joanne, we're going to be talking here soon too anyway, so I'll be seeing you in the next couple of days talking. But Joanne, this is the perfect person to talk to. When you spoke to us last week, you spoke to 2 people trying their best to talk about it. She knows more about mandate than any of us.
I do know a lot about different insurance companies.
What question do you have for Joanne?
She left. She's gone.
Oh, well, okay. We'll get her back in a
While
second.
we're working on getting her back, I will go through a couple things. So, do you have to jump through hoops? So, I'm sure just like you, there is a certain set of blood tests and ultrasounds that you do before you start treatment, right? You need a semen analysis, infectious disease screening. You want egg count numbers, saline ultrasound, or some sort of imaging of the uterus. This is something that is like standard of care, right? And yes, insurance companies want to see all of that before they approve treatment. So, there she is.
There we go. Okay. Hey,
Hi.
so nice to see you. I've been listening attentively and excited for the opportunity to ask my question. Sorry, it's kind of dark. I'm in my car because I'm waiting for my son to do a swim lesson. I mean, I feel like I'm kind of I'm a little bit of a worrywart, but I'm also like I'm in a situation where I'm a self-pay patient and I have had to do just a lot of financial rearrangement of my life to be able to afford IVF. And luckily I found new directions. I found Dr. A in Arizona, but I'm traveling all the way from California.
What do you think?
Yeah, I mean, I think you were talking about this earlier about like other countries, right? And you know, you might not see the doctor, right? You may you might have lower pregnancy rates because their equipment, you know, although they're doing the best they can, right? There is definitely quality, you know, between different equipment, right? Someone using a large incubator like a hair cell versus using benchtop incubators, there's going to be differences. Having certified gases versus just regular gas. So what I think is that I do agree with you that like there's more volume, like you would think, you know, and the quality goes down a little bit, there might be lower pregnancy rate. But on the same token, you might have people who are getting to IVF a little sooner and maybe who couldn't afford it before.
Yeah.
And so we're also going to have, you know, because I mean, right now, I mean, honestly, like we see some tough cases. I mean, in one of the chats, someone was talking about, you know, they have like stage 4 endo, you know, and diminished ovarian reserve. And like in that situation, they said in their state, there's only 2 or 3 fertility clinics and they're charging 26,000. And they only get one shot at that, right? And so the way we do that is we give them tons of meds. We try to force as many as we can. We try to make it the best one cycle because we know most people aren't going to be able to afford a second cycle. And so you're kind of right that if we're doing it through the freeway, we're going to be doing these smaller, minier cycles. You know, you're not going to probably push them as hard. They're probably not going to make as many eggs. But the pregnancy rate cumulatively will go up. It's just that the per cycle rate will go down. But I think people will change and understand it, right? Like, I mean, they'll say like, listen, yeah, we get it. The pregnancy rate per person is going to go down, but the actual transfer rate should not go down. Right. That should stay the same.
And, I have a couple questions. So, our situation, Dr. Salem, Dr. Emil is obviously familiar with our situation, but I have, me in particular, I have low sperm count and low motility, and then when we just did a egg retrieval and fertilization with my wife Shayla, and had I guess pretty low fertilization. Well, the way you described it, Dr. Emmels, was that a lot of the eggs fertilized but didn't grow, they didn't progress, and then the one that did had a genetic abnormality.
So if you take the cumulative pregnancy rate, you say, okay, I do one transfer, then a second transfer, and here's my chances of a live birth. And you do put 2 back, it might be here, but it's actually slightly higher doing 1 at a time because, as he was suggesting, if something goes wrong, let's say with one of those pregnancies, you could potentially lose the other embryo, right? So if you have bleeding, you can lose it. Now your pregnancy is higher risk. Now, you know, you end up having preterm delivery so early that you lose the pregnancies. And so it's interesting. Kara, I'm sorry, I said Lauren. Kara, it's interesting because I was always a big believer in putting 2 because I put in 2 every time. And that's because I was doing IVF back in the time when rates weren't as good. And so you always put back 2. You'd be almost crazy not to. But the rates have got so good now that as Dr. Salem said, the recommendations by the American Society of Reproductive Medicine says 1 pretty much across the board. But I do think there's still part of being a doctor and looking at the situation was it's a day 7 embryo. Is it a mosaic embryo, right? And then making those type of decisions, you want to put back more than one in that situation. So it's clear cut on what the recommendation is, but just like everything, there's gray areas, and that's when we go. And so for you, I think the big question is, I'm not going to be able to tell you what to do, but I think the question is, how important is it to, if you know you only want one more kid or something like that, and you're okay with twins, then I think it's not unreasonable. But if you're saying, hey, I want to get the most amount of pregnancies out of this, then as Dr. Salem said, one at a time is going to give you your best chance.
Dad told me that.
Thank you.
And this is this idea of even getting the people before they have infertility. I think any woman, early on, this should be tested. I think when you hit 25, check an AMH, and it should be covered by insurance. Just like we go and get, well, some of you might not, you're too young, but like a colonoscopy at 45. These are screening tests. I mean, why not screen for it? Why not find these things out, right? Then when people want to have a baby, why not involve your doctor? I'm not saying that we have to be in your bedroom. I'm saying, why not we have a way where we tell them, hey, we're going to give you ovulation kits, and then we're not going to be there, but it will come to us on a computer, and then we'll say, hey, things are looking good. And if we notice after 3 months it's not going well, we can say to them, hey, you might want to come in. There could be a problem. Why do we have to wait till it gets so bad? Why do we have to wait till someone gets stage 4 endo? Like, this is the type of stuff that I think will really benefit. And it might then lessen the load later, because we all know that one of the reasons IVF is going up is because people are waiting longer to have kids too.
Yep.
And we're seeing people before. So I think there's a lot of room to that can benefit and change. And I think using APPs are going to help. And I think finding ways to make things more efficient. One of the things that Steve Rooks said in the background, which is something we were actually looking at, a thing called Cycle Clarity, which is that company that uses AI to look at ultrasounds. And although we think it's really amazing, the goal would be is in one sweep, they can look at your ovaries and across the clinic, everyone would have the exact same measurements.
You have to figure it out with the person that's in front of you and use a shared decision-making model to say, what do you think? Here's what I know. Let's make a decision together about this.
Yeah, no, I agree 100%. And one of the questions I was asked afterwards was, how much does it cost, and do you have to go under anesthesia? So I know of 2 ways that you can do ovarian rejuvenation with PRP. The first way is the one that's most known, which is going to be intra-ovarian administration. I mean, technically you could do it without anesthesia, but I wouldn't recommend that. I think it would be very painful. So what happens is you do go under anesthesia, and then the needle's placed into the ovarian tissue under the kind of the tunica underneath it and placed in there. The second way does not need anesthesia, and that is where you go and you essentially put a catheter in the uterus, blow up a balloon, and then under high pressure, you push all of the PRP solution through the fallopian tubes around the ovaries, and then they kind of soak in it. And then that one usually is a little bit lower cost, and it doesn't require anesthesia. And the question kind of, and I'll let you answer too, because I feel bad answering this. I sometimes even wonder, like, if both should be, when you're talking about the different pricings and whether they work, I almost feel like the one where it's baiting it should be better than injecting it. Now, I know it sounds kind of weird because you're like, well, man, injecting it in, that gets it right in there. So that's the best. But when you think about it, I mean, where do eggs sit? They're not inside the ovary, right? They're on the outside of the ovary. And so if it's baiting in it, and, think of the ovaries sitting in the pelvis, they're going to be sitting at the very bottom with all this fluid there. It's going to be sitting there for hours and hours and hours. And so it's interesting. I mean, I just wonder what your thoughts are on that. I sometimes wonder if that could even be a better method, but obviously there's just not enough data out there to say what's better and what's not.
Yeah, that's right.
Is there a point where they should maybe get it removed earlier than later to, be able to preserve the uterus more? Is there a point where you would say, if you're getting to 6 centimeters, let's get this thing out, because if it gets to 15 here and it's growing fast, I'm going to have to do more surgery, more concerns?
I take it on a case by case basis. I don't necessarily do it from a size perspective, or say, hey, it's reached a 7 centimeter or 8 centimeter, and you should operate. One, I take into consideration what the symptoms are, and seeing if it's really impacting them symptomatically. And then I also look into see what is the plan for fertility. Younger patients, I'm much more liberal as far as how to really attack things and how to give them options, because to you guys' point that an AMH of someone that has an 8 or 9, and has a little bit more time to work with, a procedure like an Accessa or a laparoscopic radiofrequency ablation of the fibroid, just temporize growth and to help with symptoms, is much more of a realistic option than someone that's 43 that has been infertile for years and really is, has an AMH of 0.8 and needs to get eggs, and now trying to really move forward with an IVF cycle. Me telling her something conservative like radio frequency ablation is not the same, even though they both have 7 or 8 centimeter fibroids. So it's never a size. I think it's more so an individual goal, and from an individual goal standpoint, as well as symptom standpoint, and a plan of like where you're at with your fertility desires, and that will then kind of lay the framework of what makes sense. Because I've seen, to be honest with you, I've had patients that had 9-10 centimeter fibroids, multiple of them, get pregnant, have full-term pregnancies, deliver vaginally, and do well. And so for me to tell her, hey, you should have had a myomectomy before, when she's doing perfectly fine without my help, it might be a mistake. She's probably going to need surgery later on, but hell, let her have her babies.
I mean, please, call in, send us questions. Keep in mind, we're telling you what we think is important, right? But we're the doctors, right? We see from a completely different perspective. I mean, when I was listening to YL just a second ago, sorry, Dr. Salem, just a second ago, saying how, involve the men, part of my mind was like, I'm like, man, sometimes it's hard to get the men involved. Like, it's almost like there's jokes about I'm just a sperm donor, and I think it is important to involve them, like you said. And I think this is where you talk to your doctor, right? And just say like, hey, how can I involve them more? I think women too tend to, for them, want them to be involved, right? And so sometimes guys don't know what to do. How can I help? What can I do? And so talk to your partner. Again, that will help reduce stress. Let them know what they can do. I've seen some amazing partners. When you were talking, it reminded me of something. And I think part of what makes, I think all clinics are good. All clinics want to help people. But I think what makes some better than others, and doctors better than others, is to think about these things, right? And so when you were talking about like involving the partner stuff, it's when I have someone that I'm doing IVF, one of the first things I notice is that they're by themselves, and one day the partner's there because they can't be there every day. I'll actually say on that day, go, hey, how about we go over the instructions today on how to do the trigger shot, since you're both here, get 2 years, and we can always teach it again when it's time to trigger, but it's doing those type of things. And so you can be an advocate for yourself as a patient, say, hey, I know we're not triggering yet. You guys are going to teach me, but if you're at a clinic that's going to teach it later and you have your partner there, have them teach you it then. And so, again, as a patient, you can be an advocate for yourself. The same thing is like with OB scans. So I have patients who are very stressed out. One of the first things I ever do when I do an OB scan, and I'll admit I don't do a lot of them anymore because I'm a little bit busier, but when I do them, the first thing I tell them, the minute I put that probe in, I don't even look at anything else. I tell them there's a heartbeat. I let them know right away there's a heartbeat, because I know that's all they care about, to help reduce that stress. Because before that, it's just built up. Oh my God, is there going to be a heartbeat there? Is there not? So I just start with that, and you could just see on them, they're like, and then everything else is just measurements and stuff.
Yeah.
And so, the same thing with, I have patients who have very severe recurrent miscarriages and stuff like that, or have bleeds. And so one of the things I, will do is say, why don't we come back every week? I'll bring someone back twice in the same week if I need to, to help the stress. I'd be interested to see what you have to say, Dr. Salem, on this too. I mean, like I said, I don't get too worried about 45. I mean, are you kind of the same boat there?
Yeah, no, definitely. I mean, again, if you look at to answer your question precisely, just like Dr. Amos said, I mean, there's a little bit of some increased things that happen as men get above 40, above 45, but really we start to see it pick up a little bit above 50. So practically speaking, like what are we talking about? Well, there's a little bit of a higher miscarriage rate, for example, among women who start a pregnancy with a little bit of an older male partner, and especially above the age of 50. Again, there are some single gene mutation issues that happen, again, more so above the age of 50. These are very rare things, though, right? These are really rare. So on the whole, I wouldn't pick that one thing out. Now, here's another way to think about it too. Sometimes you don't know if your sperm donor has ever started a pregnancy before. It's unproven for unproven fertility. And maybe the 45-year-old gentleman has started a pregnancy. So again, that's another variable to take into consideration when you're talking about all of these things, because one has proven fertility and the other maybe doesn't. So, and ultimately, this is a super personal decision. And we have the tools to help you do both things, but it's ultimately your choice. And I think that's what really matters.
Thank you.
And you said you went through multiple cycles and hopefully have multiple eggs, and that does give you some flexibility, right? And so I think the one thing I would tell you that I said in the beginning is, if it's really important for you to have a pregnancy with your eggs, and if the sperm isn't good, I mean, that's a discussion you guys can have and say, listen, let's try with some of the eggs. But if it's not working, you might want to have a child with your DNA, and you may say, can I use a sperm donor? Or say that's one thing I would want to do at that time. But most of the time it's fine. I don't want people to be so worried about that. There's just all these men out there with horrible sperm. But like I said, it's just an important thing. I try to look at both sides of it. And the one thing we are lucky as guys is we always have sperm, whereas with women, there's a finite time. And so I think it's always going to look at that. Did you have any other questions or comments or about that?
Yeah. Human growth hormone has large meta studies, right, that show increased live birth rate. Doesn't help everyone and it's expensive, but there's really not a reason they shouldn't be allowing it, even if they didn't pay for it. So, I mean, it's kind of some stuff like that. I will also say that, there's insurance companies like Progeny, which is not really about the mandate. So it's just employer-based coverage that's everywhere. I'm sure a lot of employers in California have it, where, they really want you to have the best outcomes and the lowest risk. And this is something they're sort of, when they're selling their products to employers, they're like, we have the best doctors. Everyone has to be board certified. Everyone is an REI. Some clinics are trying to sneak OBGYNs in, right? But one of the things is they require a single embryo transfer always. Right. And you can submit a petition and stuff like that, but they are really serious about it. And, I think that those are some things that in the long run probably are improving patient care, because I think, it's best to have a single embryo transfer. However, I think that there are some of us who really follow the rules, and there are some times within the ASRM guidelines that it would be okay to transfer maybe more than one. But it becomes really difficult when you have these kind of rigid rules. So, for example, Progeny does not really allow you to do without jumping through tons and tons of hoops, gonadotropin IUI cycles. And for most patients, that's great because gonadotropin IUI cycles has a very high chance of twins, triplets, etc. I had a patient who had hypothalamic amenorrhea, would not ovulate on oral medicine, did not want to do IVF, and also did not need to do IVF. And all I needed to do was give her a little Menopur and she started ovulating. But I had to the amount of hoops I had to jump through. And luckily she got pregnant. She got pregnant on the first time twice. But it was it was like kind of a lot on the doctor's end too, right? Having all these like prior auths and stuff like that. So I think part of it is also just learning how to help patients, how to help the patients, how to help them get through treatment. And, you know, the providers in California are going to be new to it or newer to it, right? But like, it didn't take me very long to know like which insurance company you have. It's not like it's super burdensome to know which insurance company you have, what I need to do to help you get there.
You know, even though you might have a specific question, you obviously are watching this because you have concerns and you have, you know, questions you probably wanted to get answered.
Right. Husband's got him. I don't want you to think I'm just letting him cry in the background. I guess, so we've done IVF. For us, it took quite a few tries. And I just am wondering if we have, like, Ryan had insurance. Luckily, my husband through work, but we hit our lifetime maximum with that insurance. Is it like you get one shot, and, you know, when you have unexplained infertility and you have to go through so much, it could be this, it could be that, to figure out what's going on. I'm wondering, like, is there going to be a maximum, I guess? If you were lucky enough to have kids already, are you still going to get the opportunity to have coverage, or is it like, no, you got your miracle, that's good for you? So I guess that would be my biggest concern.
So that's that.
Have you do you ever stained inside of the endometrium before your surgeries?
You said stained it?
Yeah, like with like indigo or something, you know, just to kind of make it easier to see when you're doing the surgery.
I have not. I think that's an awesome idea to do, but I have not. I've seen so much that I can really I can find it. I meticulously find it. And one thing that I do that's not popular, but I actually go to the endometrium, like in every case, just because I want to assess the cavity. I'll make a small you know, incision there just to see and make sure that the cavity is intact, especially if it's very close to it, and just meticulously repaired, because I don't, you know, a lot of times, you know, we do these extensive myomectomy cases, and they'll have submucosal, you know, fibroids and things that are just left because you just don't know it's in there. So I like to be very, very thorough to make sure things are not. And, you know, proud to say I have so many women that have gotten pregnant. I just got off the phone with a very close friend of mine, childhood friend of mine. His wife is now 33 weeks pregnant. Now did her myomectomy maybe 3 years ago or so. So, you know, it's a lot of that's right. Awesome. So doing the right thing.
Do you enter the lower uterine segment, or do you go near the fundus when you go? Because you said you always go into the cavity.
Yeah, I try to go into the body, just make a very small. So usually I don't have to do that. Most of the patients that come to me have cavity involvement anyway, so I don't have to do that. Yeah. But you know, I try not to go low. I try to you know, go into, you know, the body, if you will, and just make a small incision just to make sure there are no fibroids or anything, and that their cavity is clear. I can assess the pathway to the tubes, and just document that, video it, and show like you guys to say, hey, this is what she has. This is everything. And you don't read my op notes, you look at video to see what you're working with.
That's great. I know we have some questions coming in here that people really want to get you to weigh in on them. So where do you want to take it, Dr. Amos? I see a few of them.
Okay, so I was literally reviewing this with a patient today who's in the almost exact scenario where, and she's also like not super comfortable using the main banks because they have so many offspring. She wants to use one of the banks that like you pay more and then they have limited offspring. So I was just having this conversation. So there was recently a settlement, like a lawsuit settlement out of Connecticut, I believe, for $36.7 million for a scenario where somebody used donor sperm and had twins and ended up having congenital CMV for the babies.
Now, the other part of that story is that I think as the risk starts to really increase, it's really important to have multiple experts weighing in on it. So a lot of times we have, like, you know, a high risk OB doctor, or maybe you have a heart issue. Maybe you're only 43, but you have a significant heart issue. We have you go see a cardiologist, and your cardiologist is going to have to weigh in and say, hey, I'm clearing, so-and-so to go through with a pregnancy. So it's this kind of collaborative approach that we're all taking as professionals to keep you safe together. And I think the issue here is safety. It's really all about safety.
It is. It's interesting though, because I think I brought this up before. You hear this a lot. Someone says, well, someone's 60 years old and they get pregnant. Like, are they going to be alive for their kids, graduation? But what's weird about that, and I brought this up, is if the woman is 65, but the guy is 40, we all still kind of shun against that. But if the woman is 35 and the guy is 60, we don't even blink an eye. We don't even go, well, he may not be there for the graduation. So it's just kind of interesting in society how we have these slightly different views. And I think it's because mothers are more of, we think of them as the nurturers, in that situation. Before we get the very last one, or anything you want to go, question was, because in the end, if you do the workup, most of the time, even if you don't find anything, which he talked about in one show, 50% of the time you don't even find anything. There are treatments that we do empirically, and over about 80% of people still end up going to have success. And so I think it's great that she's coming to see someone now, because keep in mind, OB doctors, they don't do what we do. They do their best to help. But as I always tell people, I would be very pissed if they could do what I do, because I had to do 3 years more of training. And if I had to do that for no reason, I'd be upset. So it's a big step she's taking. I mean, basically, specialist now. What do you think that there's something to that?
Yeah, no, I totally agree with that. I mean, it also takes a lot of courage to kind of make that leap and say, okay, hey, there's definitely something going on here. We need to figure out what it is. And the treatment solutions are very different. It's not a one size fits all. Like, hey, you had recurrent pregnancy loss, so you have to go to IVF. Not at all. So it's a very stressful thing to go through this. Now, I think the take home message that is important to keep sight of is the fact that even with 3 miscarriages, the vast majority of women, their next pregnancy will go all the way to them taking a baby home. So it is a very, positive outlook on the whole, but it's still one in which we shouldn't be, we should be mindful of, and we shouldn't be like ignoring the workup and the treatment.
Awesome. And you mentioned, Kate, about IVF.
Mm-hmm.
Well, I mean, one place where the cost would definitely go up is on the whole healthcare system, because you're going to end up transferring more consistently more than one embryo. So we're going to go back to the age where twins and triplets were more common. That's been a huge innovation in our field. The fact that we've been able to transfer one embryo and feel very confident about it and get a really high success rate. Now, if you have to go back to transferring 2 and 3 embryos all the time, even among very good prognosis patients, what you're going to see is a higher multiples rate, a higher rate of preterm delivery, preeclampsia, and a higher rate of babies, unfortunately, in the NICU. Every baby in the NICU is a very, very high cost, a very sad thing if avoidable. I mean, it's wonderful that NICUs exist, but if we can avoid that admission to the NICU, it would save the healthcare system a ton of money. I mean, that's just one example that would stem from having to do transfers of 3 embryos, let's say. How about you? I mean, what do you think?
Yeah, down the same line. I mean, you make a really good point. I mean, it's where we're at now. It's so much different than the past. I mean, I remember the days of like, we did transfer after transfer and it just didn't work. I mean, my wife and I, when we went through 2 embryos, we put back 40% chance, best chance. Now 1 embryo, 60% chance with PGT testing. I think there's also the point where you're talking about the healthcare system is having a child with a problem, right? So, I mean, there are people who do PGTM to, rid diseases from their family, right? And that's going to prevent a child from having that. So now, if you can't freeze embryos, how do you test these? And then you go back to like the old days of fresh, where you try to test and then, 2 days later you go and you put it back, but again, you have to discard some of those embryos. And so then you run into that problem again. So, I mean, you basically get rid of PGT, you get rid of PGTM. So people now who want to rid their family of diseases or have a disorder that can hurt their child, they can't do that. You have people who have recurrent miscarriages due to translocations of their DNA. What are you going to do there again? How are you going to do this? The cost even to the patient, if you said, well, we're going to have to do only 1 or 2 embryos at a time, it would be so costly. I mean, labs, the way they're able to keep costs down is running multiple cycles at the same time. Now, if you're only able to run 1 embryo or 2 embryos at a time, they're not going to be able to run the volume they do, and cost goes up in that. I think the other thing is legal.
And then, take us through what you're about to tell us, because this is really interesting. This is super novel. This is groundbreaking kind of stuff. So I want to, yeah.
So, for all the viewers, it's fibroids, are problematic, like I say, for 2 different reasons: size and location. Size, typically, if fibroids are so big where they're pressing on different parts of the body, organs, they can be problematic. But more importantly, location. So the way I explain it, is to my patients, is like you look at it like a house, right? So house, you got your brick and your chimney. Then you have the drywall, and then it's the part where we're actually talking in. It's the actual room where you're at. The room where we're at is where people are at. So if a tree falls on your house and it falls on the roof, no harm, no foul. Really, you won't know what's happening. You're in your house doing well. But if that tree falls through not only the roof, the drywall, and now comes to where you're at, now you have raining inside of here. That's a problem. And so those are the ones that are very problematic. And when you do that, it's the house and where you're at is extremely important, right? That's the entire focus of your menstrual cycles, where your babies come from. Like, that is sacred. And so if fibroids are putting damage to that, removing them, once you remove them, it is paramount that you meticulously repair the inside of the house, like the inside of that room. And to that point, and I tell women all the time, like, when I get in there, I have no idea what I'm going to find, right?
Number one, I want this patient experience to improve. I want it to improve because it is such a big ask for all the women out there going through IVF, through egg freezing, to come into the clinic 5-6 times over the course of 2 weeks, to get their blood drawn every time, to have an ultrasound done every time. They go, they're really putting themselves out there. It's a big, investment of time, and and just a lot of them to go through all of that. So what I'm hoping to see is, number one, a bloodless IVF cycle, meaning I really want to see our ability to understand the hormone profile by just looking at analytes in the urine. I also want to see AI-assisted ultrasound technology in which people can take home a probe and do their ultrasounds at home, and then the images are sent to us over the MR, and we will tell you how to adjust your medications based on that. You don't have to come into the clinic 5-6 times. You just come in one time, and that's for the retrieval. And then the last thing, and I think this is true of every IVF center out there, is there's a lot of communication in IVF, and it's sensitive communication. It's communication that is very time intensive. It's time sensitive. And I think, Kara, you mentioned the EMR and that whole technology. And I think we're continuously making improvements in that realm, but we have a ways to go. And I think that that's something I'm really excited about, that I do believe the future will make this more pleasant for our patients. And those are 3 things that in my mind are just going to make the patient experience a lot better. There are a lot of other things that will make the science better, I hope, in the next 5 to 10 years. But patient experience right now is a really, really big part of it. We do everything that we can to optimize it and make it good. But I think we do need some technology to improve that as well.
Thanks for your insight.
Like, listen, we had a Republican president just voted in, but 7 of 10 states also passed reproductive rights laws, and a big one of them was right here in Arizona.
Yep.
Prop 139, astoundingly passed. To say, hey, we're going to protect women's right to abortion until viability. So again, I think that we're seeing something that maybe is changing over time, where you have, traditionally you've had these two things that happen in lockstep. You have, kind of Republican candidates that always say, yes, anti-abortion and all these things. But what we're seeing, for example, here in Arizona, is we're seeing voters that probably voted for Trump and voted for Prop 1. So I think this is a step in the right direction for women's rights, that both sides of, political leanings are coming together on this idea of protecting women's rights. And as a result, I think and that's probably the most controversial one, is abortion rights. So when we start thinking about IVF, embryo creation, all these other things, I think the laws are gonna all veer in that direction even more so. And so I think while there were some concerns for a minute with what happened in Alabama, and the IVF concerns that happened there very quickly, I think what we've seen is the pendulum swing all the way back and say, hey, people want this, people want IVF, people want family building. America is very pro-family, so why would we mess with something that's pro-family? And I think that's really what it comes down to. I think it's really as simple as that. I personally am not seeing, the writing on the wall that we're going to go back in that other direction against abortion rights, let's say. Now, I know there's a lot more work to be done.
We'll finish up here soon, but 40% of women who are age 40 have fibroids. It's a very common thing. Many women have them, but the question is, does it matter that they have them? I'm sure a lot of people are hearing this. They're hearing these crazy stories, but in the end of the day, I mean, as people walking around with fibroids, they'll never know they have them, and they'll never have any issues. And I think when they hear the word, like, it's a tumor, how do you explain it to people with this idea, like when you meet them and they have a fibroid because they heard they have one, now they're scared, but you're like, what's your goals? And they're like, well, I'm fine. What do you tell them? You say, well, don't do surgery. No reason. Like, it's not bugging you. It's not bugging anyone else. So.
Yeah, I always refer back to the goal, and I talk to him and say, hey, if the only reason that you're talking to me right now is because somebody did an ultrasound and told you that you have fibroids, forget that ultrasound and forget what they told you, because it's you have 70-year-old women walking around with fibroids that are living their life with their uterus and their fibroids, and they're not bothering anybody. So the fact that the fibroids are just there and they're bothering you just because they're there, forget that they're there. When they become a problem for you, you will know that they're there, and now we need to talk. We have bleeding, we have frequency of urination, we have pain with sex, we have pain with our menstrual cycles, we have infertility issues. When we know when they're causing a problem, now we need to have a discussion, because at the end of the day, every surgery has risk involved.
Have you ever, before we jump to the next question, one thing I find interesting is that when women are more mature, so like, let's say someone's like 48 or 50 or something, and they get a normal embryo, a euploid embryo, we know the pregnancy rates are significantly less than someone who, let's say, is 42 that has a euploid embryo. And I only know this because one of the companies we use, Progenesis, we actually get to see data from all the clinics, and we can like use filters and figure out, and you see the drop as people get older. And so I've always, in my mind, the way I've always thought of it is that, it's not perfect, this testing we're doing. We're looking at large chromosomal problems. And we know that as we get older, there's a higher chance there's going to be small problems that are maybe not being picked up. I just wonder what your thoughts were on that, because that's one thing that in the beginning we thought all were the same. They're all euploid. And now we're realizing, they're not all the same.
No, not at all. I mean, I completely agree. And, there are so many factors that go into that, same embryo, right? You're looking at an embryo that's let's call it a 5AB on day 6, and it's between a 30-year-old versus a 40-year-old woman. And those are going to have, different success rates. And it's because, there are different processes that are happening just inherently to these embryos, and it's definitely something that we see now. The other part of it is, well, the pregnancy rates are still pretty good. You have a 5AB, day 5, day 6 embryo at 40. I'm feeling pretty good about that. So, I think there are some differences, but I think that in the whole, the process, it still works, and those differences aren't colossal. I think once upon a time before PGT, when you were doing an embryo transfer, you might have seen a 3-fold difference if you were just transferring a single embryo in those two groups. And now that gap has really narrowed.
Yeah, absolutely. Yeah, and the one that we did, the ones I've seen are like usually after 44. That's usually where you start seeing a real decrease, and almost like that same gap you talked about in the past.
Mm-hmm. Mm-hmm. Yeah, and that's hard, and that's that goes back to that theme about reproductive lifespan that I'm very interested in, is how can we kind of extend that reproductive lifespan a little bit, and then use the tools that we have currently.
One thing that's interesting too is, and I'm a little bit more mature than you, but we've been around for a pretty long time. When I first started, there really wasn't that much PGT.
So for me, I personally feel that no fibroid is too big. It just isn't. And to be honest with you, and people would be shocked at this, the bigger the fibroid, the less the damage to the uterus is. If you look at some of these like ridiculously large fibroids, oftentimes they're pedunculated. Yeah. They're really not damaging the uterus, to be honest with you. So we have a big fear about them, and it's really not as bad. It's more so the smaller ones, and when women have really advanced disease where they have 70, 80, 90 fibroids that are in there that are riddling the uterus, where it becomes more of a problem. But some of the bigger ones are really, surprisingly, are not as bad. There's some more of my easier cases, and for me, I stand true to that. To date, I have the only 2 patients that I've had to unfortunately perform hysterectomies on when doing a myomectomies were 2 women with cancer that had leiomyosarcomas. Yeah. Other than that, I have been able to successfully, knock on wood, but successfully do a myomectomy in every single patient that I've operated on. And it's been some tough ones. I don't want anybody to get confused. It's been very tough. I've been on the fence with several of them. To thought one woman went to DIC. You can't control that. If you're bleeding, you're on the fence there. I've had some very, very damaged uteri to where I actually had to call out to the family and say, listen, this is a lot of damage. Is this what we want? Talking to her husband. And they reassure me that yes, this is what she wants, and I do it. It's because it's my, to me, it's not our job to play God. It's not our job to say someone can or cannot and use our opinion in it. For me, I never tell a woman, oh, it's impossible for you to get pregnant, or this is something that you cannot do. Speaking in definites to women is not only heartbreaking, but it's inappropriate, I think. So my conversation to them, and I'll kind of walk everybody through. I have a very, very pertinent question.
So the cells are arrested for a long period of time, potentially 5 years, 10 years. And then that embryo will start dividing again and can lead to a pregnancy. So there can be a 6-year delay in this case, for example, between when you froze the embryo and when you put it back in, and yet the embryo is still only 5 or 6 days old, if you will. And this has been one of the huge innovations in our field that allows people to bank extra embryos and then go back. And many times from just one IVF cycle, they might have 2 children, maybe even 3 children sometimes from just one IVF cycle if they had a bunch of embryos frozen there. So I think that's what the question was getting at. And I hope I answered your question there.
Yeah. And I think there's actually a lot of studies being done on this right now, is how long can this embryo be frozen for? And so one thing that Dr. Salem mentioned was there has been a change. So in the past, we used to do slow freezing, which is where we used to freeze over time. And then the purpose of that is to prevent crystal formation. So as everyone probably knows, water, as it gets colder, it expands, which then that's why its density is less and it floats on top of water. And that's why ice floats. The problem is those crystals destroy the embryo. And so for years, we actually used to freeze embryos at the PN stage, which is the day right after fertilization, because some of them had like less water contents and things like that, and they froze better. Some places even used to freeze even at morulus because, again, less water content. When you become a blastocyst, you have this big old fluid-filled center, and that fluid-filled center can get crystallization. So what's unique about vitrification, as he said, it becomes a glass-like state. So instead of not freezing, you're removing most of the water, you're putting lots of solutes in there, and then you rapid freeze it. And so the question about after 6 years, can you do it? The answer is yes. We don't think there's any issue. There has been many pregnancies from embryos that have been frozen for 6 years. Just my clinic alone has been over 10 to 12 years. I'm trying to think of probably 15 years, probably the most right now.
So that's why I tell them, when I go in there, I'm removing them all. And if you're having issues with pregnancy and we have fibroids that are close to the cavity, that it's in your best interest to remove them if you are in that position where you need this to happen sooner rather than later.
Yeah, absolutely. Dr. Salem, we got some questions here. So Dr. Salem, I'll let you start some of these off here.
Yes, absolutely. I mean, I see a lot of questions flowing in here, and a lot of people have some excellent questions. And one of them is about hormone imbalances and the risk of developing fibroids, and kind of what your experience is with that, Dr. P. And we're happy to give our 2 cents on this as well. But what's talk a little bit about who's predisposed. I mean, a little bit of this question is talking about who's predisposed to having fibroids. And I think we can kind of talk about some other things that you were mentioning earlier as well. And so, yeah, why don't you just take it away there?
Sure. So the most promising study that I've seen, study out of University of Chicago, where they found actual genes that code for fibroids. And for these women that have these genes, it's almost similar to, a BRCA or Lynch syndrome or any of the other oncogenic genes that we know about, that they have a very, very high propensity for growing fibroids. And they are doing research as far as preventative measures to prevent some of these fibroids with vitamin D and some of the other things that they found that have shown some promise. But the thing that they have not figured out is why certain women will have a 2-centimeter fibroid for 20 years versus a woman that will have a 2-centimeter fibroid 1 year, and then 3 years later it's a 15-centimeter fibroid. That information is the biggest mystery, and that's what I talk to my patients all the time. And so in my personal experience, what I experience is that African American women do have fibroids at a higher clip, but more importantly, they are the ones with advanced fibroid disease more so than any other culture or race. And there are a couple of reasons that I think that are not well studied or paid attention to as to why that is.